crazy. And obviously, when you get your own skull upstairs after we do the checkout this afternoon, do review it. We'll provide you all with pipe cleaners to probe your own holes and practice all of the foramina of the skull and the cranial nerves that are associated with each one. So, Max, we got good lighting, good cinematography
No,
here.
we got good everything.
Thank you. Okay. So I brought 2 skulls because I'm picky about the carotid canal. So, all right. So the skull's a little tipped. So on your screen, the big screen, this is anterior. Your anterior cranial fossa is going to have holes associated with cranial nerves 1 and 2. In the middle of the anterior cranial fossa, this is the cribriform plate where the olfactory bulb of cranial nerve 1 sits. All of those little perforations in the plate are where dendrites extend from the nose up to the bulb. So bringing the sense of smell from the nasal cavity up into the cranial cavity. Most of the anterior cranial fossa is part of the frontal bone. So above the orbits, these bony roofs of the orbits, all part of the frontal bone. We have what's known as the frontal crest. The frontal crest right here, part of the frontal bone. But centrally, this is where the ethmoid bone is suspended. We'll talk more about the anatomy of the ethmoid bone, I believe, with the oral and nasal cavities. So stand by for follow-up. When we get to the posterior side of the anterior cranial fossa, we hit the threshold between the anterior cranial fossa and the bilateral middle cranial fossa. So this right here is the lesser wing of the sphenoid bone. The sphenoid bone is that really weird shaped bone. It kind of looks like a Halloween bat. It has a lesser wing on the inside, and out laterally, we'll see the greater wing of the sphenoid bone kind of tucked deep to the zygomatic arch and sitting anterior to the large external part of the temporal bone. So all information that we'll cover in more detail with the anatomy of the skull. The second foramen associated with the anterior cranial fossa allows cranial nerve number 2 to exit the inside of the skull. The optic nerve uses its own separate hole to get into the orbit. We'll find that it's located medial to these little bony projections. We call those anterior clinoid processes. Some of this stuff, you'll see it on the structures list. It's not highlighted in red. The red stuff is the need to know takeaway in this moment. All of the foramina, everything else, you know, kind of one of those things like might as well learn it sooner than later. We'll be reinforcing some of these other structures like lesser wing of the sphenoid bone, clinoid processes for the next couple weeks. So those anterior clinoid processes, they're anterior boundaries or margins of your Turkish saddle. This is your sella turcica, this very central region within the cranial cavity. It's basically the middle of that weird bat-shaped sphenoid bone. So inside of the Turkish saddle, like think of sitting on a horse saddle, the middle part is where your butt goes. This back part kind of supports your back. This front part is maybe where you like hold on if you're on a horse. So if your butt's right here, this is the middle of the saddle, and this is known as the hypophyseal fossa of the sella turcica, or the pituitary fossa. So your pituitary gland, it dangles off the hypothalamus right here. All stuff we're going to talk more about next semester. So that brings us to the middle cranial fossa, where many cranial nerves critical for dentistry are going to exit the skull. So when we come along the lateral side of the Turkish saddle here and pass to the front, we pass underneath this lesser wing of the sphenoid bone. This is where the superior orbital fissure is located. So everything that has to get to the orbit that isn't the optic nerve goes through this fissure. So we're talking cranial nerve 3, 4, 5, 1, and 6. The superior orbital fissure is your bony exit from the middle cranial fossa to the orbit. So if we can kind of tip this a little bit. Sorry, I know it makes some people dizzy. You can kind of see at least the more medial part of the fissure right here. Right there. So this is the medial part of your superior orbital fissure. Allows 3, 4, 5, 1, 6 to exit into the orbit. When you come right behind it, right here, not a perfect perforation on this skull, but this is the hole that allows V2 to exit the middle cranial fossa. This is the foramen rotundum. The foramen rotundum, it's on the sphenoid bone after it kind of already starts sloping superiorly towards that superior orbital fissure. So that's why it's not always perfectly visible in these top-down images. But again, right there, that is foramen rotundum. This oval-shaped hole right here and right here, this is foramen ovale. Foramen ovale allows 5-3 to exit the middle cranial fossa. Now, we'll talk about this big hole in a second, but I want to show you this other skull because there's an extra hole in this skull that is noteworthy in addition to those foramina. So I'm kind of tipping the back of the skull up to give us a slightly different view of that middle cranial fossa. Something like, oh, there we go, there we go. Okay, so right behind foramen ovale, this little hole and this little hole. Very spherical, like perfect small round holes behind foramen ovale. That's a foramina that we haven't mentioned yet, but it's nice to know about now so we don't confuse it with foramen rotundum and foramen ovale. That's a hole known as foramen spinosum. It's on your structures list and it allows a large artery to pass from the neck up into the middle cranial fossa. That's where your middle meningeal artery will enter the epidural space. A patient that has an epidural hematoma, like 90% of the time, it's the middle meningeal artery that's experienced a rupture or a bleed. So we'll talk plenty more about that. Foramen spinosum is a good one to know about, and it has that close relationship with foramen ovale, often confused with foramen rotundum because they're on each side of foramen ovale and both very circular in shape. Excellent. Okay, so we're cranial nerves 1 through 6 now, all taken care of. So we have one more structure inside of the middle cranial fossa that is not a cranial nerve, but again, Warren's mentioning, it's the hole that I have the pipe cleaner coming through. So you can see on the side where I don't have the pipe cleaner, we have this like big gaping hole. So this is known as the foramen lacerum. And when we look at the skulls in the lab that have the dura mater over them, and we don't see, you know, all of these trenches in the bony wall, we're actually going to cover that hole up completely, and it's plugged up with cartilage. So really this big hole, it doesn't have anything pass through it top to bottom. What it does have is the internal carotid artery kind of running right over its superior surface. So inside of the petrous part of the temporal bone is your carotid canal. If we look at the base of the skull, We do have large, very spherical holes that allow the internal carotid artery to exit. So this would be internal carotid, kind of just shooting right to the base of the skull from the anterior neck. But see how I can't get my probe through that hole? It's because the carotid canal, it's not a hole straight through the skull, but rather it has this little horizontal zigzag in it. So the internal carotid artery, it enters this bottom half of the canal, and then it has to veer medially through the petrous part of the temporal bone. So on a carotid angiogram, you're always going to see this S-shaped component of the internal carotid artery. And that's because it has to veer medially and wiggle through a horizontal segment of the carotid canal inside of the petrous part of the temporal bone before it emerges on the inside of the skull in this position. So we can see where it runs horizontally still, we're running right over the foramen lacerum, a cartilage plugged hole that doesn't have any cranial nerves shooting through it, and then the internal carotid artery has to pass up to the base of the brain. Right here is where it would contribute to the circle of Willis, which is your big anastomosis to the brain that we'll talk about next semester. So the carotid canal and the foramen lacerum, they're near each other, but if I have a pin going straight through a hole, you can't be carotid canal. Carotid canal has a zigzag in it. So a carotid canal tag, we probably want to probe the little hole with a pipe cleaner because you can actually follow the contours of the carotid canal inside of the petrous part of the temporal bone. So right on the lateral side of the sella turcica is where the internal carotid will pop up out of the carotid canal and the bony anatomy, and we'll see a cross section of the vessel with the nubs of the cranial nerves when we look at the skulls in the laboratory. Excellent. So that's all things middle cranial fossa that we want to know now. Last but not least, some items in the posterior cranial fossa. I'm going to rotate a little bit, not trying to make anybody dizzy, just got to get the right view. Okay. So, we see a big hole in the posterior cranial fossa. I was going to talk about jugular foramen, but obviously the biggest hole, the really big hole, that's foramen magnum. So that's where the spinal cord goes. But we have this big gaping hole here. This is your jugular foramen. So remember, cranial nerves 9, 10, and 11 exit the jugular foramen. They're bilateral and pretty close to the foramen magnum. So we can see where they're both located here. We have to come higher up on the petrous part of the temporal bone in order to see the hole associated with cranial nerves 7 and 8. So your facial nerve and your vestibular cochlear nerve, remember, they enter the temporal bone. So right here, if I were to Dremel out this region, this is the arcuate eminence, is what we call it in surgery. If we had to knock that bone out, you're just landing right on the cochlea and the semicircular canals. So that said, this hole right to the back side of that region is your internal acoustic meatus. So the internal acoustic meatus takes us to the inner ear that contains the cochlea and the semicircular canals. Facial nerve doesn't innervate those structures, but rather we are going to find the facial canal inside of this petrous part of the temporal bone, and the facial nerve is going to do things totally independent of the inner ear. It will send a branch through the middle ear, which will be a hot topic for us to talk about in a few lectures from now. Last but not least, hypoglossal canal for cranial nerve 12. If we again kind of just rotate things, we can see this canal really like right in the margin of the foramen magnum. So those hypoglossal canals, if we think about the general top to bottom organization of all of the cranial nerves, they have to be the lowest one. Cranial nerve 12 is the most inferior. Those canals sit in the margins of foramen magnum and allow the hypoglossal nerve to exit the posterior cranial fossa and enter the neck. So for all of these holes, as time goes on, you'll be able to address the starting place, which is a cranial fossa, and an end place. So the neck is the site for all cranial nerves exiting jugular foramen, hypoglossal canal, foramen magnum. If we're talking about the spinal accessory nerve, we're going from the posterior cranial fossa to the inner ear or the facial canal, considering cranial nerves 7 and 8 and the internal acoustic meatus. And then for all of our dental heavy branches in the middle cranial fossa, we basically connect to another space that houses additional cranial nerves important for dental medicine. For example, your foramen ovale, it connects the middle cranial fossa to the infratemporal fossa. This is the area where your IA is coming from. It's where all things mandibular division of trigeminal will be housed. It's where your muscles of mastication are. So it's a big hot spot for us. Whereas foramen rotundum, it's going to connect the middle cranial fossa to a separate fossa, the pterygopalatine fossa. The superior orbital fissure will connect the middle cranial fossa to the orbit. So you have a place on each side of these holes. We're allowing things to pass away from the inside of the skull towards a region where their target organs are more closely associated. Excellent. Okay, that covers all things really critical for your structures list that you'll see posted for today. So I'd say today, tomorrow, sometime before our next lecture, practice identifying these holes on your own skull in front of you, because obviously being able to see the skull three-dimensionally is going to give you a better appreciation of the orientations of these spaces and the passageways we just defined.